Hello, Dr. Yan and classmates. My name is Jennifer Doyle, and I'll be presenting the HepA program, which is the Hepatitis A Prevention Program for Unsheltered Individuals in Penobscot County, Maine. Addressing hepatitis A is one of the health priorities identified by Healthy People 2030. The specific goal is to reduce rates of infectious disease and improve health for people with chronic conditions. To start, I'd like to briefly state the definition of hepatitis A, and that is it's an infectious disease of the liver. The liver processes nutrients, filters impurities in the blood, and is essential for a healthy immune system. There are varied levels of severity of hepatitis A, and it can go from no symptoms to flu-like symptoms to jaundice, which is yellow or dark urine or stool and yellow skin and eyes, and in rare cases include hospitalization or death. It is highly transmissible and spread by person-to-person contact and through contaminated food and drink. For my assessment of the community need, I first looked at the data. Nationally, in 2021, there were 5,728 cases of hepatitis A reported in the U.S. However, the CDC reports that it could be up to 11,500 due to significant underreporting and underdiagnosing. In Maine, from 2021 to 2022, there was a 28% increase in new hepatitis A cases. There were 64 cases, or 4.1 cases per 100,000. 54% of the cases reported injectable and non-injectable drug use. 16% were reported as unsheltered, and again, that could be a conservative number considering many of them were not actually diagnosed. None of the cases were vaccinated. There was also a Health Alert Network report stating that in Penobscot County, hepatitis A is the fastest growing for people who are unsheltered due to poor sanitation by living outside or in close contact in small spaces or shelters, sharing of needles, unprotected sex, and lack of preventative medical care and education. So for my needs assessment, in addition to the data, I plan to have outreach workers who work with unsheltered folks every day, who have developed trust, to go out and interview the participants or the potential participants to see what their level of knowledge of hepatitis is, if they know what their risks are, if they know how it spreads, if they know how to prevent it. And also, in addition to the surveys, I will look at the community assessments, such as the Shared China, the Community Health Needs Assessment for Penobscot County, which is a report compiled of data analysis, interviews and observations, focus groups, and much more. This is just a picture I included of a typical encampment. We see these in Bangor, which is the biggest city in Penobscot County and which is where many of the unsheltered individuals live. As you can see, there is no evidence of sanitation, running water. People are in close contact, living in sort of a congregate setting under those tents, and certainly doesn't look like a clean living situation. Social determinants of health associated with unsheltered or unhoused individuals have to do with economic stability or lack of financial resources for housing, food, sanitation, and transportation, education or lack of education on the risks of hepatitis A and prevention, social and community contacts, distrust of healthcare and community services, stigma, shame, exposure to others who are hepatitis A positive, health and healthcare, again, lack of trust in healthcare, lack of available providers, multiple comorbidities, living in outside or congregate settings, and neighborhood and built environment, again, just the obvious living in shelters and being homeless. The community at risk I've identified as Penobscot County, Maine, but more specifically Bangor. The population of Penobscot County is 153,000 or 201 towns, but the population of Bangor alone is 31,558. It's the third most populated in the state. And Bangor is the regional center for communications, transportation, community services, healthcare, for which people come from rural communities and take long trips to access the programs in Bangor. Bangor has a higher concentration of people living in poverty and with mental illness, substance use, and houselessness, and has a critical shortage of affordable and safe housing, less than 1%. Bangor has a low area median income, according to the U.S. Census, has slow development and wage increases, and the number of unhoused is increasing each day. Per Maine housing, there are 4,258 homeless people in Maine, and locally we don't have statistics, but in talking to outreach workers, we have about 150 to 200 in Bangor each day, and it's growing. The goals and objectives screen is kind of busy, but just to briefly state, Goal 1 is to increase 2-dose hepatitis A vaccine uptake in unsheltered individuals in Bangor, Maine, and to minimize hepatitis spread to individuals in the community, to increase knowledge of individual risks and ways to prevent spread of hepatitis A in unsheltered individuals in Bangor, Maine, and to increase access to community services for unsheltered individuals in Bangor, Maine. For program interventions, I use the evidence-based CDC epidemiology program model, which takes a multidisciplinary approach with epidemiologists, health departments, pharmacies, shelters, prisons, substance use disorder treatment facilities, and needle exchange programs. The CDC epidemiologists partner with organizations that have long-standing trusting relationships with high-risk individuals to provide these services. And we're taking the ecological model, which addresses the disease and the social determinants of health that contribute to the risks of the disease. So the specific interventions that my program will have is number 1, vaccine, hepatitis A vaccine given at regularly scheduled clinics each week at strategic places where unsheltered people live so that they don't have to travel. Participants will also be offered the second hepatitis A vaccine 6 months after the first dose. They'll also receive education provided to participants about what hepatitis A is, signs and symptoms, testing and treatment options, the risk of getting hepatitis A as an unsheltered individual and spreading it to others, and ways to prevent hepatitis A, such as no sharing of needles, proper hand washing, condoms, and care around food or drink. And thirdly, connection to community services, which will be very important to address the social determinants of health surrounding their risk. They'll be offered a case manager to assist with community resources, including financial assistance, housing assistance, applying to Maine Care, connection to healthcare providers, and a needle exchange program if needed. We will do this by adding a part-time nurse to an already existing health department immunization clinic. The evaluation of the program will have 3 main evaluation questions to determine program outcomes. These questions will consider the trace factors, time frame, recipient, amount of change, or other effects. We'll first do a pre-test, post-test design, and we'll ask how many participants after the first year in the program can state at least 3 environmental or behavioral risk factors for contracting hepatitis A. We'll also have a 1-group time series asking how many participants in Penobscot County received the first dose of hepatitis A vaccine and how many received both first and second doses in the first year of the program, and to be evaluated every year. And then the ecological design, which will ask what is the incidence of hepatitis A disease in Penobscot County, Maine, before the program initiation compared to 1 year after, and evaluated every year. Also, the evaluation of the data will include statistics from case managers regarding connection to services and the success of that piece of the program. In conclusion, I'm very optimistic that this program will help address the growing rates of hepatitis A in unsheltered individuals by vaccinating, educating, addressing social determinants of health to provide more sanitary and stable living and access to health care. Thank you very much and have a great night.